Hello and welcome to this episode of GLI Live. My name is Donna Cryer. I am the founder and CEO of the Global Liver Institute, and I have the great pleasure of being your host for all of these episodes, but this episode in particular, which I think is very special because it bridges both scientific expertise and patient expertise in a really unique way. So I am welcoming Dr. Mark Lewis, who is head of GI Oncology at Intermountain. Hello, Dr. Lewis.
Hi, Donna. It's so nice to be with you, and thank you for the invitation and the opportunity to chat. I'm looking forward to it.
Thank you so much. So I hope people are aware, and if they are not, they will be after this episode, that liver cancer and the majority of liver cancers are hepatocellular carcinoma, and we'll refer to that as HCC during the course of this episode, is one of the few cancers that's rising, and it has a 5-year survival rate of less than 20%. So it's a serious, urgent issue within the cancer community, within the liver community. And you have been not only an expert practitioner and patient advocate, but a vocal proponent of liver cancer care across multiple platforms, in person and on Twitter. So I look forward to getting into that. But maybe we'll start with how you came to oncology.
Yeah, certainly. So, although I'm speaking right now with an American accent, I'm originally from Scotland. And the reason that's relevant is I got into oncology via a tragedy that was uncovered in my father, and completely by accident. So there's a term in oncology and medicine of an incidental oma, a tumor or a mass that you find, again, looking for something else. And so our family's kind of origin story here is we were moving to the United States. As a public health measure, when you do that, you are required to get a chest x-ray. And this far predates COVID. This is actually looking for tuberculosis. And so the call we got from the embassy was sort of a good news, bad news. The good news was my father didn't have TB. The bad news is there was a mass occupying almost his entire right lung. And at the time, he was 42 years old. He was a very healthy man by all accounts. He was, for what it's worth, a non-smoker, although as we can get into, especially with HCC, there's a lot of destigmatization we need to do around cancer. And there's plenty of lung tumors that can develop in non-smokers. So we found out that this mass was there, and almost as soon as we arrived in the States, my father had his entire lung removed, and so survived on one lung for the rest of his life. He called it the slow puffing process of proving its redundancy, which I thought was such a beautiful turn of phrase. But because the operation was incomplete, there was cancer left in his chest in the area we call the mediastinum. It's a very tight space, basically behind the breastbone and in front of the heart. And so he had radiation there, which, as you can imagine, was pretty brutal, especially in the late 80s. So that affected his ability to talk and his ability to swallow. And then, unfortunately, from there, the cancer spread quite painfully, actually, to his bones. And so he was in tremendous discomfort. Again, this man had been teetotal his whole life and was now requiring morphine to control the pain. So it was really an enormous influence on his quality of life. And we'll get into later how that's influenced my thoughts about cancer treatment. And then, unfortunately, he died after chemotherapy. And so at that moment, when he passed, I was 14 years old. I was a freshman in high school. It's a very formative age, as you know. And I was very fortunate because my dad's oncologist, and almost no one would do this, said, "Hey, listen, you seem interested in science. Would you like to work with me?" And so every summer in high school and college, I got to work in the same clinic where my dad had gotten treatment, which at first, I'll be honest, was a little bit kind of off-putting. But once I got used to it, I got to follow this man around, and I worked my way up the ranks. I was a medical assistant. I was a radiology technician, did vital signs and x-rays and that kind of stuff, and learned all the really important sort of parts of medical machinery. But the most important thing I did was just follow him and observe. And he had this wonderful way of treating his patients as people. Because, as you're well aware, we are very bad in oncology sometimes about being so focused on the tumor that we forget the host. We forget the person that tumor is inhabiting. And he had this great sort of trick, if you will, and this is in the old days of paper charts. You'll remember you used to go to the doctor's office and just see a wall of colored charts. So he would literally take notes in the margins, and it would be these tiny little details about the patient, you know, the name of their grandson or what their favorite sports team was. And he would always somehow weave that into the talk, the interview. And it was so real and human and personal. And it taught me, you know, that's really the way you need to approach oncology. And it's actually gotten harder to do because our electronic medical records now are so, you know, data driven and have structured fields. There's actually not a lot of room for this kind of marginalia. But regardless, I was later validated when I got into medical school. I already knew I wanted to do oncology, and they taught us that short of psychiatry, oncology lets you have the closest relationship with your patients. And I mean that in, of course, the most professional and appropriate way. It can border on, feel like friendship. And I'm not, you know, I'm not blind. I know there's a power differential, and I know I'm not exactly my patient's best friend. But by seeing them as people and not just as, you know, vehicles for data, it really humanizes the whole field. And so that was my entry into oncology, and frankly, it's what sustains me in the field. Is it a very sad profession? It certainly can be, but it's not all doom and gloom. And I'm actually thrilled to be talking to you, an expert in liver cancer, because you of all people know how the times are changing. Not quickly enough, not effectively enough, but we are at long last seeing, and fairly rapidly, progress in HCC. And that's the thing about oncology is, if your understanding of it is rooted in the experience of, say, what happened to your dad in the 80s and 90s, or a beloved grandparent before that, it's like a whole new world now. And things have gotten significantly better, both on the effectiveness side and on the toxicity side. So I witnessed in my dad 2 drugs come along that were complete game changers. And so in 1991, he nearly died because he had no white blood cells. And his oncologist walked in with this new shot called Neupogen and said, hey, we can actually bring your white blood cells back. And this was in the ICU. I thought he was going to die right there. And I watched this injection bring the white blood cells back. And I was, you know, I was a boy at the time, but it was like a magic trick. I was like, this is unbelievable. And so even the pharmacology I found appealing. And then the other drug that was a real game changer was Zofran. So just being able to tolerate chemotherapy with less nausea is huge. It was huge for my dad. It remains such an important part of what we do for patients. And, you know, when the American Society of Clinical Oncology sort of did a retrospective and looked at the first 50 years of oncology, you know, one of the top 5 advances was anti-nausea drugs. So not our ability to cure, say, Hodgkin's lymphoma or testicular cancer, just making our patients vomit less. And so what I'm really getting at is we need to puncture some of the myths around chemo and some of the myths around treatment, as you know too. Not all cancer treatment is chemotherapy, and we can certainly talk about that. So long answer, but that is my kind of circuitous route into the field. And it's the reason I stay in the field, even though it's very hard sometimes to lose patients. I know it's getting better all the
time. Mark, thank you so much for that. You know, I think about how we can ensure that there are oncologists and hepatologists and gastroenterologists, you know, in the future, and that aspect of mentoring, of early exposure to, you know, math and science and role models in medicine. I know that my husband, who's a physician, participates in an AMA's Mentoring in Medicine program, and he works with a lot of the different physician and medical societies in which he's been involved over the course of years to, you know, to provide that exposure. Because, you know, if you're, particularly if you don't come from a family of physicians, if you don't have a role model, you don't have that exposure, it can seem sort of impossible to have a career in medicine and to make sure that you take all the classes and do all the things that, you know, can prepare you for such a career. So I think we're all the better for your mentor and early exposure allowing you that opportunity.
Well, that's very kind of you say. That's wonderful. Your husband does that. And I was just going to say very briefly, you know, the other thing that's weird about medicine is obviously there's other professions that are similar, but we really are almost set up like a medieval guild where you have to do apprenticeship, and you work your way up in this very hierarchical fashion where it's, and I've never served in the military, and I'm not saying it's exactly like this, but you've got your medical student, and you've got your resident and your fellow, and then your attending physician. And it really is actually, in its best incarnation, it's a wonderful sort of way of fostering, like you're saying, and mentoring trainees, and sort of handing down the things that you learned, and kind of paying it forward. That's in its best incarnation. Now, there's all kinds of examples of trainee work hours being horrible and people being abused at the bottom of that totem pole. But regardless, I think you're right. I think we have to set an example. And again, one of the things I'm trying to say loud and clear is oncology is actually not as depressing as many people think. And there was a really interesting study done a couple of years ago where they took sort of medical students who were undecided about what they wanted to do, and they let them spend 2 weeks in the hospital seeing oncology patients, so the inpatient ward, and then 2 weeks in the clinic. And interestingly, if you polled them or surveyed them after they were in the hospital for 2 weeks, those are obviously the sickest people, they're less likely to go into oncology. But if you polled them after they've been in the clinic, which is 95% of my practice, they were more likely. And so I try to emphasize to people all the time, yeah, it's tough, it's emotionally a grind, but it is a lot better than a lot of people think.
Absolutely. And the relationships that do develop between patients and their physicians, particularly when you are as vulnerable as you are for cancer patients and families and transplant recipients and families at that edge of mortality. And there have been so many wonderful books, written about that point by patients and physicians. It is a very special bond. As you're weighing options and thinking about the value of treatments in the course of a life, and making projection of will they hang on long enough to go back to school. And I remember having a conversation, should I start law school? And my law school classmates at reunion years afterwards asking me, if you were told that you were gonna die in a few years, why'd you go to law school?
Yes.
And I was like, well, I trusted them. I really, it never occurred to me that I'd actually die. I thought, as correctly that we would prevail. And so whether you can hold on for, a child's graduation or wedding or some other, event, that relationship that you're working on, jointly with your care team to, becomes so vital and so real.
Yeah, and I think the term they use these days often is legacy building, right? And I'm so glad, of course, that you persisted with your goal and your dream, which obviously has been enormously successful. And I have to say, my last point there, to kind of tie things up with my father, while he was dying, he wrote a book. And he knew he was not going to live to see its publication. In fact, it didn't come out until 7 years posthumously, because it's a really deep theological tome. It's not, in the Harry Potter series, and it was not easy to find a publisher. But my mother, bless her, for her late husband, got it into print. And my point is, my dad knew that wasn't going to be something he would get to see, but it was still very important for him to do that. So again, to your point, even when you are grappling with almost certain mortality, there are still these wonderful things we can do, and again, leave legacies for others to see and follow. So anyway, it's a wonderful gift to me that I can read his words.
So why do you think when there are so many powerful stories of cancer, and we've certainly learned a lot about stigma reduction from the lung cancer community, but there are equally as stirring stories about liver cancer patients, liver cancer tragedies, trials and triumphs. And yet we hadn't seen until very recently, until, a lot of nudging by GLI, but we hadn't seen liver cancer embrace NIH and CDC and the Cancer Moonshot and American Cancer Society and ASCO, and GI ASCO used to be very, very small, and there wasn't very much liver cancer at all. Why do you believe that liver cancer had gone, under the radar really, and under recognized for so long?
Yeah, I hate to say this, but I think there's two answers to that. One is stigma, and the other is nihilism. So the first thing is, and again, doctors are people too, and I'm almost ashamed of this, but we are definitely prone to cognitive bias. And as you're well aware, there are some pretty significant comorbidities that are adjacent, at least, to HCC, including viral hepatitis and alcohol-induced cirrhosis. And because of that, and again, it's awful. I almost feel like HCC was ghettoized away from other GI cancers as something that was viewed as more of a lifestyle problem, when of course it's not, right? And so that I think historically was a bit of a problem. And thankfully, I think the current generation of oncologists, hopefully we are much more wide-eyed and can realize that's a horrible way of thinking, and that should not be driving our allocation of research dollars or interest. But secondly, for the first 10 years or more of my career, I had a single drug I could give to patients with HCC. And frankly, again, oncologists and even research scientists are prone to giving up when we've tried the same thing again and again and gotten the same result, which is failure or lack of ability to improve upon the result. And, the story of sorafenib obviously dominated, I don't know, 2007 until maybe a year ago in HCC. So much so that when I would go to tumor boards, so here at Intermountain, we have 12 conferences organized around tumor types. And so we have one that addresses the rest of the GI tract, so like colon and that kind of thing. And then we have one that's specifically about the liver and the bile ducts. And, for years I would attend it, and hepatologists would sort of, almost roll their eyes when I brought up sorafenib. And I understand why, because it was a drug that came with a tremendous amount of toxicity. And, depending on how you look at it, not a lot of efficacy. And so there was almost this assumption that there was nothing that we could do. And so I think that 1-2 punch of stigma and nihilism is what set the field back. But now, thankfully, we're turning a corner, and there's all this new hope. And I don't think it's hype. I really think it's hope for HCC patients. And that really is changing the paradigm dramatically.
So I know our first challenge is making sure that patients are diagnosed early enough to take advantage of all these new treatments, and helping internal medicine, hepatology, all these practices that are treating people with existing liver diseases, whether that's viral hepatitis or NASH, or any of the other drivers of liver cancer, to make sure that they are diagnosed at an early stage rather than a late stage. There are more diagnostics available to do that. So can we maybe talk the screening diagnostics part, and then I want to get into all the new treatment options available.
Yeah, absolutely. So yeah, in terms of screening, as you know, one way I think about screening is the smarter approach is going to be risk stratification. So for instance, I'll actually draw a parallel here to another cancer that's very vexing in my practice, and that's pancreas cancer. And I've actually had a form of pancreas cancer myself, so I can speak to this a little bit. So the problem with pancreas cancer is, much like HCC, we often find it far too late. And obviously there's a bit of selection bias, but 85% of people, when they come to my clinic with pancreas cancer, incurable. So either it's already metastasized, or it's so intertwined with the blood vessels around the pancreas that there's not a surgeon on earth that can cut it out. So just taking the general population and giving everybody a CT scan to look for pancreas cancer is not going to work. The radiation burden and the cost of doing that is far too high, and outweighs the pieces of benefit of catching a few people early enough to cure them, right? So the smarter way of thinking about it is risk groups. And I mentioned the electronic medical record earlier. As much as doctors might malign it, and there are a lot of hassles, I'll be honest, with putting all this information into the computer, I think we're also starting to see the upside, which is you can actually pick out patterns. So for instance, one very promising pattern for focused screening is adults who are losing weight. Okay, so again, this is a very easy metric. You're probably weighing every time you go to the primary care doctor, and developing as adults diabetes. So normally in America, if you develop diabetes in adulthood, we're talking about type 2 diabetes. So you're insulin resistant, and it's usually because you've gained weight. So that signal of unintentional weight loss and new onset diabetes basically tells you something's rotten in Denmark, something's wrong with the pancreas, and it's time to look at the pancreas. So those are the people who I suspect would benefit from at least some form of imaging, and likely a CT scan of what's going on at the back of their abdomen. So to pivot to HCC, as you know, we've known for a long time now that the people that have known cirrhosis from almost any cause should have focused screening for HCC, including alpha-fetoprotein testing, and typically ultrasound as a non-radiation carrying imaging modality. But the last thing I would say there, which I've seen in almost every cancer type, is the rise of the self-advocating patient. So we live in the information age. Again, I won't pretend like the playing field is completely level, but there's, I'd say 95% of the data and references are available to me are also available to my patients via Google, okay? Now, even there...
A paywall, though.
Right, exactly, yeah.
Having had to pay for a lot of journal articles that I really, really wanted to see. So I know that the National Library of Medicine and others are addressing there, and there are more open access journals. But as a patient who frequently searches online for information for myself and for others, and know particularly a lot of cancer patients are looking for information, that it's dangled out.
Yeah, and actually, so that was the 5% I was hinting at is either it's stuff at closed conferences that for whatever reason we can't talk about, like say a trial in progress, where it would be inappropriate to disclose data too early, or paywalls. Now, I know we're going to talk later about social media, but that's actually a beautiful way of sort of circumventing paywall. And you're right, the numbers are eye-popping, even for publicly funded research. I sometimes go and looking for an article, and it's something like $80 to access it once, right, and it's going to disappear. You know, it's going to self-destruct like it's Mission Impossible. It's like, it's unbelievable, you know. And so there is this whole information economy that unfortunately is cost prohibitive for many, many people. But aside from that, and the fact that you've hit the paywalls just shows how deep you're trying to go into the literature, which is absolutely wonderful. And it kind of proves my point, which is that patients and advocates are incredibly sophisticated. I tell my colleagues all the time, not that my colleagues are arrogant or sitting in ivory towers, but you cannot underestimate the savvy of these people. Partly because their lives are at stake, and no one
motivation to be told that you might die. I'm like, a lot of stuff that they didn't try to teach me in law school, based on that fact alone. Yeah.
You're if you're that invested, right? If it's your life on the line, you're going to do your homework. Again, what this is leading to is patients are really remarkable now, I think, at advocating for themselves. And so let me give you an example from my own life. My very first day of my fellowship, so I did my oncology training at the Mayo Clinic in Rochester, Minnesota. Famously a place that you go if you have a problem you need diagnosed. Okay, that's one of its great strengths, is amazing primary care under one roof. So my first day, I had abdominal pain, and one might readily think, oh, that's just nerves. You're having stress because you're starting this new phase, and it was. I was apprehensive, but this was beyond that. In fact, at first I thought it might be appendicitis because it was kind of localizing to my right lower quadrant. Regardless, what I had was a high calcium level. And I won't bore your audience with the physiology here, but basically calcium is, you can have too much of a good thing. And if you get too much of it, it basically slows down your gut, almost not quite to the point of blockage, but certainly very, very uncomfortable. A condition called ileus. And that's what I had. And at that moment, I realized what was wrong with me, because my late father, who we started off talking about, he had calcium his whole life too, and it was never explained. And frankly, once the cancer was found, all the eyes were on that. No one was thinking about his calcium level. But I had this eureka moment. And again, I was in the right place at the right time. I had just enough medical training to be dangerous. I knew there was really only two conditions, one benign and one malignant, that can cause calcium to be elevated in consecutive generations, so a hereditary problem. And so I went to the doctor I'd just been assigned at Mayo and said, I have this problem. And frankly, I was, again, incredibly fortunate to be able to exercise sort of some professional courtesy and some leverage and say, listen, I really, really want you to order these tests for me because I'm convinced this is what I have. And honestly, he thought I was a hypochondriac, but I was.
Every medical student Doesn't every medical student they've come down with?
Yeah, it's called medical student syndrome, and at one point in medical school there was an Ebola outbreak in Africa, and one of my friends got a nosebleed, and I know I shouldn't joke about the virus, but he was like, "Oh my gosh, this is Ebola," and of course it was just a regular nosebleed. But anyway, so yes, when you've been exposed to all this kind of esoteric knowledge, and you know almost everything that can go wrong with the body, it's very, very difficult to look at yourself with complete objectivity. So yeah, we might call that medical student syndrome, and I certainly had medical student syndrome that day. But here's my point. My process of getting diagnosed correctly would have likely gone on for years longer had I not been at that point a doctor, and if I had not been able to sort of use my connections. And again, I hate to say that; it almost sounds like I'm gloating. But people with my condition, on average, go something like 7 to 10 years from onset of symptoms to correct diagnosis. And unfortunately, in the middle, it's all delayed diagnosis, it's misdiagnosis, and that is going to foster, unfortunately, quite a lot of mistrust in the medical community. On the other hand, it empowers patients to really take hold of the reins and try to drive their own healthcare. And I think that's where we're getting to. So sorry, go ahead.
And has it, and how it has informed, your career. And I think of it in the context of having gone through that myself. And I was talking to another advocate the other day, and I was like, well, we can just call and get you to. She's like, no. And she was so sick. She was like, I want to feel what it is to do this as a normal patient, so that when I'm advocating, I know exactly pressure points. I'm like,
not selfless. Oh gosh.
Mountain. But I often think it's hard. Think about, if it's this hard for me, being an attorney married to a physician, I'm now on the board of a hospital, I run this organization, I talk to care. What do other patients do? And I know they die is unfortunately what they do. And so shortening this diagnostic odyssey, which we're working on in cancer and in NASH and in pediatric and rare liver diseases, is so important, because as you and I know, it is too hard for people, and the burden is often placed on them with no tools, no resources, no roadmap. And shortening that diagnostic journey can be the difference between life and death.
It's so beautifully well said. And actually along those lines, so the model in medicine has shifted from paternalism, telling you what you're going to do, to ideally shared decision making. So I tell my patients all the time, like, I'm here to offer recommendations and counsel and some professional experience. This is your body, and the whole ethical principle of autonomy is predicated on the fact that you'll make the decisions about what happens to you. Along those lines, one thing I've said online quite a bit is you absolutely deserve a second opinion if you feel that you're not getting the answers that you need. And my real sort of adage there is, if a doctor tells you not to seek a second opinion, that is a reason to seek a second opinion.
Yes.
No one knows everything. And in fact, even in oncology now, my first job out of fellowship, I was seeing every type of cancer while trying to specialize in GI cancer. And I realized pretty quickly, I can't do this. I cannot maintain both breadth and depth. I would even argue, not just doctors, but I would argue there's no oncologist on earth that I know of who can manage everything at this point, not with the level of expertise that's going to satisfy the patient. And so that's again where there's this beautiful, ideally sort of shared responsibility, without putting too much of the onus on the patient, but knowing that because they're so invested in their care, they have the right to seek further answers. And what I was going to get at in terms of ownership of data, I actually just had some testing earlier today as a patient. And when we're done, I'll get to check my result from my phone. And what's beautiful about that is it's making information more accessible and portable. And it's also allowing patients to see, hey, gosh, there's something wrong here with my results, and to ask questions about that in a manner that they probably wouldn't have done before. And what I'm really getting at with your HCC population, or people that are at risk for it, the liver is a remarkable organ. Now I'm going to nerd out a little bit as a GI oncologist, but it might actually be my favorite organ. I hate my pancreas. My pancreas has betrayed me many times. But my liver is my savior, and it's incredibly regenerative. It's also very sensitive, right? I tell patients if the liver had a personality, it's quite easily offended and inflamed. And liver function tests, which are built into a lot of routine testing, are actually kind of a fantastic, if indirect, screen as to if something's up with the liver. So I've actually had a couple of patients, believe it or not, come to me via these portals, and they've seen that the liver function's off, and then they've actually pushed for testing, whether it's an ultrasound or a scan or something, and then we found there's a problem. And typically, those are the people I'm finding early enough to be involved in their cure. So again, it's a perfect example of self-advocacy resulting in better health outcomes.
It's exactly the type of thing that we teach in our GLI Advanced Advocacy Academy, where we have patients and caregivers who want to make that leap to becoming patient advocates. Many times they've already done that in their own lives, or for their own families, or for some of the communities online, or even some have started small organizations. But we make sure that no matter what type of liver disease they sort of come from, their condition of origin, that they know about all the different types of liver diseases.
Right.
And that they're able to get every year we get a presentation from the liver branch at NIH about your liver terminology and your liver lab work. Understanding the lab work is so important, because often, even though it may be performed, it sometimes is overlooked. And we've had patients who have said, oh, my liver enzymes have been elevated for years. And nobody said anything about them. And so we want all of the graduates of what we call A3 to be able to know themselves, and also to be able to talk to their communities, whether online or in real life, about look in your portal. We did a webinar on navigating your patient portal, and being able to take advantage of all of the information that now, on the basis of a lot of advocacy and policy, and I served on the HIT policy committee, back in the day, and it's so exciting to see, my lab results appear, and imaging results, pathology results coming, and even, most recently, the notes.
Yes. Isn't it amazing? It's taken us this long for you to read what we write about you. I mean, it's unbelievable. So I wanted to say two things there briefly, if I may, Donna. So one phrase I hate in medicine is the difficult patient. That's often just meant a patient that is asking questions. And as we're seeing here, and I know I'm preaching to the choir, it is perfectly acceptable, in fact, appropriate and just to be inquisitive about your own results. So I tell my patients all the time this story. So my Scottish grandmother, God rest her soul, had a heart attack on a Sunday and didn't tell anybody she was having chest pain until the Monday, because, quote, you don't bother the doctor. And thankfully she survived that, because now her physician grandson tells his patients, I want you to bother the doctor, okay? If something's wrong with you, or there's a result that's troubling you, I want us to talk about it. Because here's the other part I want to say. Modern physicians, and this is not like, oh, pity these poor, well-paid professionals, we have a bit of an information paradox. We now actually have so much information to absorb that it is actually easy, I have to admit, to miss things, especially small details. So one of the information streams we've already hinted at is research. Things are getting better all the time, and you really have to be on top of your game and keep up with it, which is very difficult for a lot of folks to do. And then the other data stream is coming from your patients. So again, I'm going to check my own results later. I've also got a computer over here absolutely brimming with new information I need to read about the people under my care. And so what I'm getting at is, particularly in the primary care setting, I have the utmost respect for PCPs. My wife's a pediatrician, and so I love her and I love what she does. But the average primary care doctor is probably seeing on a daily basis, I don't know, dozens, maybe 30 plus patients, and ordering tests on a lot of them. One analogy I love for primary care is, imagine that you're standing by a train track, and you see a carriage go by you, and you have to pick out in the blur of faces the one person that's sick. That's primary care in a nutshell, because most of what you're doing is health maintenance. You're helping keep people to remain healthy, but you also have to have your diagnostic antenna up for the person that is ill and needs further attention. And my point is, patients can be a therapeutic ally there. They can call attention to abnormal results and not just write them off. And so I think, again, the best way of thinking about it is not an antagonistic relationship. And frankly, you know, I know I'm speaking to a lawyer, there's a lot of medical legal implications for missed results, right? So I think that this dialogue between patient and physician is more, we can pay more authentic testimony to it now than ever before. It's not just lip service, it's really happening. I try to do it with my patients. And again, the fact that they have access to almost everything I do in terms of their results, it really encourages that conversation. And often they'll come in and I love it. They have at least read their scan report. They might not have been able to see images. And we talk about it. And it's a wonderful entree to a true back and forth, as opposed to the paternalistic, I'm the oncologist, you're the patient, you're going to do what I say. So why in that intense data stream should they be adding Twitter? The thing you have been fabulous for using Twitter as a communication tool and commentary on medicine and other topics. Why do you use Twitter, and what value should other physicians find in it? Yeah, well, thank you for asking. And I know you're on Twitter as well, and you've been on for longer than I have, and you've really seen it evolve, I suspect. So my Twitter story is very interesting. So my first day on my first real job, so once you finish your fellowship, then you're a fully fledged oncologist and you get to go out into the world. So my first job was MD Anderson Cancer Center, renowned research facility. And day one, my chairman sat me down in his office, and I thought, oh man, I'm gonna get like, a quiz on, do I know my chemo drugs, or maybe I'll get some sort of very overarching, view of the research mission. And he said, before I left his office, he said, you got to sign up for Twitter. I was like, and I went home that day, and my wife's like, oh, how was your first day at MD Anderson? And I was like, I have a Twitter account now, which is not what either of us were expecting. But he was so brilliant. So this was 2012. His name's Mike Fish, and he's still very active on oncology social media and just a great guy. He said, you can use this as a curation tool. What he meant by that was, and it was so smart. So first of all, it took the pressure off me. There was no need to be performative. He said, you can just listen. And I know there's all kinds of sort of epithets about, oh, you're lurking online. You can use Twitter however you want. If you just want to set up an account and use it to absorb information from other people, that's totally fine. Not everybody has to be vocal and active. I will say the platform works better if you amplify the content of others that you like by either retweeting it or liking it. That's kind of the beauty of it. But regardless, so to get to your question, there are these sort of factions or hashtag-driven communities on Twitter that allow you to get very, very granular in what you're looking for. Or you can follow you or your organization. You can see who you follow. You can kind of follow the chain through the network and see who are the sort of respected voices in HCC and HCC advocacy. And yes, there's all kinds of counter arguments that, oh, this is one big echo chamber and it's just a bunch of people patting each other on the back. I can tell you it's certainly not that. I've had some pretty vocal critics on Twitter, and that's okay. I've learned people will say things and do things online that they would never do in real life. So you always have to remember that. And also, I far too late to the game learn to mute and block, and the most egregious offenders report, and then they fall off the platform, and it's a much better place for everybody. But that's maybe 1% of the conversation. The vast majority of it, especially around medicine and oncology, is wonderful. Sometimes there's pretty vigorous debate, and it's really fascinating too, I think, especially for maybe a non-physician to realize we're not omniscient, and because of research and because of the evolving nature of our field, again, very few things are completely definitive, and a lot of the things that are coming along so fast need to be discussed. And dialectic is the driver of science. This argument, counter argument, meeting in the middle, that's what actually pushes us forward. So anyway, for a host of reasons, I think Twitter is a great tool for gathering information and having that information been vetted by at least some of your peers. As Dr. Fish told me that first day, the good stuff bubbles up to the top. He's absolutely right. That, again, is the beauty of Twitter, sort of magnification, amplification, is the really, really important things are going to come up to your attention. And that way you don't have to do all the reading, which again is virtually impossible. And then the other thing I might say is I enjoy it as a platform because I feel like it humanizes oncologists. And you may have heard me say this in other settings, but it's such a powerful example of our bad PR. So one time I was doing a talk and I was curious. I was like, how would I figure out what the public thinks about us? I said, I know what I'll do. I'll go to Google, because as you know, Google has an autocomplete function, right? So you type in phrase and it fills in the rest. So all I typed in was oncologists are, and then I saw what came up. And I kid you not, it was oncologists are criminals, oncologists are murderers, oncologists are confused, liars, the list went on. None of it was good. There was nothing like oncologists are wonderful, oncologists are virtuous. It was all this negative stuff. And don't get me wrong. Well, I was shocked at the time. I thought, I've absorbed it. I absorbed that blow. And it's because we, for many, many years, have been conflated with our treatments, right? Like famously, no one should want chemo. And as I mentioned, even with my dad, in the past couple of decades, the toxicities were dreadful. He lost his hair, his immune system was decimated, he was horribly sick. It's very easy to start confusing the practitioner with the poison, right? And then the other thing is, we can talk about this when it comes to research endpoints. We have actually allowed, unfortunately, surrogates to slip into our work to the point that some of the things that we think are important are so far divorced from what matters to our patients that we seem tone deaf. And so what I'm getting at here is, I'm no saint. I've got warts and all, and I like to show them actually on Twitter. In fact, just this morning, as I mentioned, I was undergoing testing. I think it's really important that I document that I'm a patient too. I want people to know that. But by humanizing the profession, I hope, and I realize this is a pretty big goal, I hope that people trust us more. Because frankly, the only way forward, aside from pure blind luck, is research. And we've had a problem, as you know, with oncology clinical trials in particular, people feeling like guinea pigs, people thinking we're just mad scientists in white coats, and again, potentially risking horrible, horrible adverse events. And so I think by being people, by actually showing our identities and our personalities, I hope it allows us to be less of this sort of abstraction of scientists and oncologists, and just be seen as, humans are trying to help other humans. I mean, at the end of the day, the core interaction in medicine, once you strip away all the computers and the scans, is me talking to people. And I love that about it. But that's very, very hard to convey outside the exam room, because you potentially violate people's confidentiality. So the only way I know how to do that in a manner that respects my patient's privacy but allows me to waive my own confidentiality is on Twitter.
I think there's also been, additional value to demystifying some of our, as you went to our research process, but our regulatory processes as well, because you've served, as I have, on FDA advisory committees, you a little more recently than I have, just last week. And so helping people know that the people who are making these decisions and thinking through this information are real people, are approachable, and so just give us a little bit of insights, as we bring this to a close, on how the shifting, availability and positioning of treatments, the evolution and advancing of research to make innovations available to patients, but how real people, real practitioners like yourselves are thinking through these issues and helping the regulators do their work. So just give us a little behind this.
Absolutely. So first of all, I'll say, I know you and I intersected last week too around the FDA. So that was my very first time serving on as what is called the ODAC, the Oncologic Drugs Advisory Committee. And I have to be honest with you, it completely opened my eyes, because it's easy again to think of any institution like the government as just this big faceless machine. Like the FDA just can be an abstraction, right? It's where drugs come from. But then when you actually realize that there's people involved, obviously in receiving the drug, but also in adjudicating their worth, it becomes a lot more emotionally compelling. And one of the things that again moved me so much about the ODAC, and you were one of the people that did this, is the part where they opened the hearing to allow public testimony. And some of the stories from patients in particular are they're so moving, to the point that you actually end up feeling bad as a person that you would ever vote to remove any drug from the list. But just as a little bit of background, because things have been moving so fast, and particularly because immunotherapy is now available. When I started my fellowship, I thought about cancer care as essentially 3 different tools, if you will. So chemo, radiation and surgery. That was almost. You can throw in some hormone therapy, but regardless. And now immunotherapy, I would argue, is the fourth column. And because immunotherapy came along so quickly, I gave my first immunotherapy to a melanoma patient in 2011, so almost exactly a decade ago. Wow. And to see how far it's come since then is really remarkable. But it's also created a challenge for the FDA, because these drugs did come along so quickly and now have so many different indications. They granted, in some cases, as you're well aware, accelerated approvals. So approvals that were contingent upon later endpoints, and traditionally really hard, sort of cut and dried endpoints like survival, things that you ought to be able to demonstrate given enough time. And so what was happening last week is they had several drugs that had what were called dangling approvals. And so they were in this limbo between their accelerated approval and potentially final approval. Another thing I'll say is this is an advisory board, so the FDA doesn't exactly have to follow what we say, but the votes, I think, are still pretty consequential. So it was interesting because the day I was voting, there was 3 drugs on the table, 2 of which I voted against, and 1 of which I voted for. And one of the ones I voted for was pembrolizumab and the second-line treatment of HCC. And again, just to peek a little bit behind the curtain, for that very specific instance, the sponsor, Merck, is about to have a trial that should answer the question, is pembrolizumab doing what it's supposed to do in second-line HCC? So because we were on the cusp of having that data, we actually voted unanimously to extend that approval, okay? Everything else, though, was a matter of pretty great debate. There were no other unanimous votes on the day I was voting. And it was a really interesting sort of collision of head and heart. Like on the heart, you would have your emotions, again, appropriately moved by patients saying, this drug or this combination of drugs saved my life. And you have to acknowledge that. I mean, that's just such a powerful example. On the other hand, again, trying to be a more objective scientist, you have to have certain data and certain endpoints to justify extending these approvals so they don't just keep going and going without end. And for the 2 no votes I cast, I could not foresee that data was going to be available ever. And so thus I voted no. And it's funny, you can't please all the people all the time. Obviously, there are some patients and advocates who are understandably upset that we would deprive them of any opportunities. And I'll point out there are still trials. There are still compassionate use programs from the sponsors. And so I don't feel like we completely pulled the rug out from under these people. On the other hand, I've got some pretty vocal critics online who said, oh, you should have voted no to everything. And the FDA should not have allowed any of these approvals to continue. Taking a pretty hard line on survival endpoint.
It's important to know that, that there are these really vigorous arguments on both sides. And so it is difficult, and a very important public trust being on one of these advisory committees. And it certainly does speak to, the importance of well-constructed trials, getting, as much as GLI is on record for, our conversations with FDA, we are equally as vigorous with our conversations with the sponsors to provide the data, to also be helpful in, patient-centered trial design and the feasibility of trials, and then, understanding, well, gosh, you're not able to complete the data because so many patients are dropping out because they get too sick or die. How can we make sure that there are patients that can be in trials long enough to get the data that we all want? And so understanding all of these issues and being able to explain them to patients and family members and regulators and the scientific community and the sponsor community, is a lot of our work as we try to get the research advanced, the data advanced for regulatory and other purposes, and access to evidence-based options. So
that's well said. And I'm going to say 2 things quickly because I know our time is short, but one of which is you're absolutely right that the eligibility criteria for many trials are, in my mind, too strict because the populations they study don't mirror the people I actually see. So this whole notion of real-world evidence, we have to do a better job of mirroring in the study populations the people that are actually getting treated in our clinics. And then the other thing I'll say is, and I'm a big sort of advocate for this, the two endpoints that matter most to patients, and this seems like I'm stating the obvious, are survival and quality of life. And there are literally dozens of other endpoints that have snuck into oncology trials, things that are more easily or more quickly measurable than those two metrics, that we have come to accept. So response rate is a perfect example. Even our criteria for what we deem a response are actually fairly arbitrary. And I've had plenty of times, a heartbreaking number of times, I walked into a room and said, "Congratulations, your tumor is smaller by some criterion." And the patient will look at me and say, "Well, why don't I feel any better?"
Right.
Just making something shrink isn't necessarily the goal. The goal is making sure that translates, and it does sometimes, not always, longer life and better life. And when we allow ourselves to accept the surrogates as scientists, we're doing our patients a tremendous disservice. And advocates like you are so important for constantly reminding the research community what really matters. And again, my critics from last week, and I totally understand that part of the role of serving on a public-facing committee is you are going to hear from everybody. Think that survival is so important as an endpoint that any of those drugs that did not meet their pre-specified survival endpoint should not have been allowed to continue as approved. And I get that. I hear them on that. However, as I mentioned, one of my votes, the yes vote, was for a drug and an indication where I think we'll have that answer very soon. So those are the two things that I try to remind my colleagues and myself when I'm thinking about trial design. Those are what matter most. And the quality of life thing is really pretty elusive, as you might imagine. That's typically been a pretty tricky thing to capture, which is why a lot of people don't measure it, is it's so evasive and hard. But we have to try. And the phrase I probably hate as much as difficult patient is manageable toxicity. When you hear that is an alarm bell going off. That there's probably some sort of smoke and mirrors going on with the language, because when someone says manageable toxicity and you look at what they're talking about, it's usually a list of side effects that they would not be willing to incur.
Right, like who's managing this?
Manageable to whom?
Yeah.
So I know I'm preaching to the choir, but that is for your audience. That's something to watch out for sure.
Dr. Lewis, I just want to thank you for your advocacy in every way, as a family member, as a patient yourself, as a practitioner, as a researcher, and as a public servant. And thank you. I know we went overtime today, but I couldn't think of a place to end this wonderful conversation. Thank you so much. And I know everybody who watches and listens to this will as well. So
thank you so much, Donna. It's been great.
Thank you. And thank you to everybody. You can find this and other conversations on globalliver.org and across our social media platforms, including Twitter. So #HCC and #LiverTwitter. So until next time, thank you.